Good afternoon and welcome to the Center for Interdisciplinary Health Workforce Studies webinar on value-based care and implications for the nursing workforce. My name is Christy Friedman. I'm the program manager here at the center, and we're pleased to have you joining us for today's webinar, which is the final of our webinars that have focused on value-based care delivery. Before we get started, let me make a few center announcements. First, Center Director Peter Bierhaus and colleagues Jennifer Perloff and Kate DeRoche have just published an article entitled Comparing the Cost of Care Provided to Medicare Beneficiaries Assigned to the Primary Care Nurse Practitioners and Physicians in the January issue of the journal Health Services Research. Briefly, the study analyzes national Medicare data and finds that patients managed by a nurse practitioner over a 12-month period cost the Medicare program less than those managed by a physician. You can find more information about this paper on our website at healthworkforcestudies.com. Second, center investigators John Graves and Peter Bierhaus have also recently published a study in the journal Medical Care that found that nurse practitioners are more likely than physicians to practice in rural areas of the nation. They also found that areas that did not expand Medicaid were particularly vulnerable to the issues accessing providers, and that scope of practice laws did, in fact, impact provider access. More about this research is also available on our website. Third, the center has recently posted on our website data on the characteristics of the physician workforce and a separate data brief on the physician assistant workforce. For both physicians and PAs, we use ACS data to examine trends around numbers of employed over time, hours worked, earnings, age, diversity, and work setting for both of these types of providers. We are also working on a lineup of spring webinar presentations that will cover some of these aforementioned papers as well as other new data related to the nursing workforce. We will announce these webinars in our upcoming newsletters. And finally, speaking of newsletters, do you know someone who would benefit from receiving our newsletter updates? Please let us know or direct them to sign up for our mailing list on our website in one easy step. Again, please visit our website for these and more information at healthworkforcestudies.com. Now turning to today's webinar, we intend to allow for discussion time of about 15 to 20 minutes after our speaker concludes her presentation. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many questions as we can. We are also recording the webinar today and will have it posted to our website. We have posted all of the previous webinars to our website, including last month's value presentation by Betty Rambert. You can also find presentation slides posted within the website's event calendar. Our presentation today closes our series on value-based care and implications for the nursing workforce. I would like to allow Peter Bierhaus, Center Director, to take a minute and let him introduce our speaker. Pete.
Everyone. Thanks, Christy. Good afternoon to everyone. I'm broadcasting live from our studio headquarters here in Bozeman, Montana at Montana State University, where the skies are a little overcast, but we received 2 inches of fresh powder last night, so the mountains are beautiful and the skiers are happy. But with all that in mind, let's focus in on today's presentation. And this is going to be given by a friend of ours for many years and a friend of the health workforce community, Dr. Erin Fraher. Now, many of you know Erin, but for those who don't, Erin has worked as a policy analyst and health workforce researcher in the United States. She's worked in Canada and in the United Kingdom. Erin is the director of the program on health workforce research and policy at the University of North Carolina at Chapel Hill. For almost 15 years, Erin has led the work of the program to provide policy-relevant research aimed at informing state and national debates about how to best educate and deploy healthcare professionals. Erin is an assistant professor at the School of Medicine at UNC Chapel Hill, and she holds a joint appointment in the Departments of Family Medicine and in the Department of Surgery. Her current work focuses on assessing what educators, employers, and other stakeholders can do to retool and refigure the healthcare workforce to meet the demands of a evolving and transforming healthcare system. Now, finally, Dr. Fraher earned her PhD in health policy and management from the University of North Carolina, her master's in public policy from the University of California at Berkeley, and her Bachelor of Arts from Wellesley College. Erin is going to provide some thoughts on how we might retool the existing nursing workforce to meet the demands of our changing healthcare system. She's also going to discuss what new skills and regulatory frameworks might be put in place to optimize nurses' contributions to these emerging models of care delivery. So now I'm very pleased to turn the microphone over to Erin. Erin, take it away.
Okie dokie. All right, you should be able to see my screen. Thank you very much, Peter, for that very gracious introduction. And as Peter said, today I'm going to talk to you a bit about nursing roles and what we need to kind of look forward to in a changing healthcare system. But I want to start with what many people believe is the burning question. We're going to talk a little bit about the nursing shortage, and then I'm going to ask you, do you think that's the right question? And I'm going to try to shift the dialogue away from that question to another question that I think is more important. Then I want to start kind of with just a brief discussion of the context of new healthcare delivery and payment models, and talk about what sort of general influence they'll have on the nursing workforce. And then we're going to talk about old school versus new school approaches to workforce planning. And you know, I'm famous for sort of laying out issues, and some people call me to task on that and say, okay, then what are we going to do about it? So we're going to talk about how do we get there from here, and then we'll have some time for Q&A. So that's the plan. That's what you signed up for. Here we go. So I apologize. This is a busy slide, but you know, there is this shortage narrative in nursing, and it goes like this, the narrative. Our population is growing, it's aging, we have increased chronic disease burden, we have more folks covered with the ACA, with health insurance coverage. You know, that's going to mean more demand, and that demand will tax the nursing workforce, and we won't have enough nurses. And so there's been national nursing models. HRSA has done a model, others have done models. Some of those models say, yeah, we're going to have enough nurses. Some of them say, yeah, we'll have enough nurses in these states, but not enough in other states. Other models say, no, we're not going to have enough nurses. I'm going to steer that question today and invite Peter and the rest of you to engage in a different webinar on that question. I'm going to dodge that one and say, let's not have that discussion. Let's talk about whether we're going to have the right mixes of nurses in the right locations, specialties, and practice settings with the skills and competencies that we're going to need in a transformed healthcare system. So one of the things that, you know, the context in which we're operating is let a thousand flowers bloom. This is a very American approach. Let's experiment, experiment, experiment. So we have all these growing patient-centered medical homes, accountable care organizations, and these new organizations, these new care delivery models or care testing model called the accountable health community. The accountable health community. We're going to talk about that. CMS, the Centers for Medicare and Medicaid Services, is funding all of these experimentations, really just trying to foster, you know, figuring out which of these models will get us better quality outcomes at lower costs. And then, as you all know, Secretary Burwell recently announced that by 2018, 50% of Medicare payments will be tied to value. So basically, we're looking at a very different world in terms of care delivery models and in terms of payment models. So if you had to summarize in one slide, what are the key characteristics of all of these models of care and all of these new payment models? Well, the goal is really to provide patients with more comprehensive, accessible, coordinated, and high-quality care. All that at lower costs. And I think one of the most important issues is there's this strong emphasis, very strong emphasis on primary and preventative upstream social determinants of health. What happens to the patient before they even make it into the healthcare system that's affecting their health? And care is integrated between these medical subspecialties, right? One of the big problems with our care system is it's so fragmented. So a lot of these models of care are trying to increase and integrate care between medical subspecialties, between home health and nursing homes. But one thing that's often overlooked is they're also trying to integrate care between the healthcare system and community-based social services. And we're going to talk more about that. Another really flagship component of health reform is the use of electronic health records, right? What are we doing? We're monitoring patient health and population health, and why are we doing that? Well, we're trying to use the data to figure out which are those patients that are frequent flyers in the ED. Where are those geographic areas where we're seeing a lot of negative outcomes? Where do we need to be targeting our efforts? So the data from EHRs is feeding into our sort of figuring out where we need to be targeting our efforts. And those efforts are focused both at the patient level for certain kinds of patients, say with diabetes or with chronic disease, but they're also focused at the population level. So which communities do we need to be targeting? And payment will be based, as I said, on value, not volume. So one slide, drinking from a fire hose, that would be what I think are the key characteristics of these new models of care. So one of the things that struck us in our center was we go to all these great conferences, and we talk to people, and we listen to these seminars, and we listen to talks, and everyone's talking about new care delivery models. They're talking about payment, and they think if you change the care delivery model or you change the payment model, bingo, it's done. But we thought much less effort was focused on really understanding the workforce implications of these new models of care. And so we conducted a literature synthesis. This was funded through our center grant with HRSA, collaborated with a PhD student here named Rachel Mockdat and Jackie Halliday, who's in family medicine with me. And basically what we found from this extensive literature search is we're going to suggest to you that we need to move from old school to new school approaches. So the old school says, will we have enough nurses? The new school says, does the nursing workforce have the skills and competencies needed to function in new models of care? So these patient-centered medical homes, what are they emphasizing? Care coordination, population health management, patient engagement, patient education, health coaching, data analytics, patient engagement, quality improvement, and a whole host of new functions. And one of the things that struck us was the early evaluations of these new models of care were not really showing these glorious outcomes that everyone had hoped for. We began to think, could this be because the education system's not adequately preparing graduates to practice in these new models of care? And I'm not just talking about nurses. I'm talking about physicians. I'm talking about pharmacists. I'm talking about PAs and NPs. This is not unique to nursing. Or maybe it's not just about the new grads not having the skills. Maybe the existing workforce isn't retooled with those skills and competencies that are needed in these new models of care. And have we even figured out what all these skills and competencies are? I'm really a fan of Bodenheimer's work, and in some work that he did in 2009, he says, you know, it's really workers with the right skills and trainings who are integral to the ability to align these new models of care and constrain cost and improve care. So that's the reframe number one, away from numbers towards sort of content, skills, and competencies. My second reframe is people love to ask, you know, how many are we going to need, Erin? What's the recipe? I sometimes feel like somebody wants me to say, you know, you take a physician and a dash of nurses and a teaspoon of MAs and you mix them all together. And I'm being cheeky, but I think the question we need to be asking is, what are the roles that are needed in that healthcare setting, and how could different skill mix configurations meet patient needs in that different geography or in that different practice setting? There is no one right recipe. We can look towards skill mix configurations that are, for example, more successful at improving health outcomes or lowering costs. But what that skill mix looks like is going to be very dependent upon the context. If you're in a rural community versus an urban community, whether your community uses more family physicians or whether you have more specialists. There's a whole host of issues going on here. And one of the things as we looked at the literature that really struck us is that when practices have begun to transform, they've sometimes used existing staff, sometimes they hire new staff, but it's complicated because some of the roles that they're looking to fill, say, around care coordination or care transitions or case management, have similar functions but different titles. Other roles have different functions but the same name. So what's a patient navigator to you? To many people, a patient navigator is someone who helps the patient navigate say, in oncology services between their primary care provider and specialists. But patient navigators during the implementation of the insurance marketplace were also people who helped people access the insurance exchange. So those were patient navigators meant two very different things. The other thing we noticed in the literature was, depending on the setting and the patient population, the roles are often filled by different types of providers. This is what I just said. In some practices, for example, and Sue Skillman's done some nice work on this, in rural practices, electronic health records, management was done by the nurse if she was available and in the practice, or he was. In some places, it was done by the medical assistant. In some practices, it was done by the office manager. So those roles may be filled by very different people, different professions. But two of the most common roles that we see are roles that focus on coordinating care within the healthcare system, and what we're calling boundary spanning roles that coordinate patient care between the healthcare system and community-based services. Okay, I'm going to talk about care coordination first. Boy, care coordination is big and getting bigger. So there are all of these increased incentives to keep patients out of the hospital. And as you all know, last year Medicare began paying $42 per month, per patient per month, for patients with 2 or more chronic conditions. Nurses are most often the health professions taking on these roles as care coordinators, case managers, and transition specialists. But they're working with teams of providers, pharmacists, social workers, dietitians, and others. And one of the things that struck us is most of these care coordination roles are care coordination within the healthcare system, okay, between different types of providers, between home health and primary care. Okay, let's shift our attention to a different type of coordination. Also growing quickly are these boundary spanning roles. Now, these boundary spanning roles, I like to think of them really shift the focus from visit-based interventions, what happens when the patient comes in to seek health care, to population-based strategies, where we're reaching out to communities and patients and populations in their homes before they even come into the clinic, right? So 2 examples of these are panel managers. Panel manager is a role that assumes responsibility for patients between visits, and they're going to use electronic health records, cancer patient registries, diabetes registries, and they're going to identify and contact patients who haven't come in for care. And these are often medical assistants, but they can also be nurses or other staff members. And so they're finding people who are missing appointments or not seeking care when they need it. But we also have a whole host of people who are building on the fabulous literature that says if you engage patients in their own health care, your outcomes are going to be better, right? So we have this growth of health coaches, and their job is really to improve patient knowledge about diseases or medications or healthy behaviors. And again, these may be MAs, nurses, health educators, social workers, community health workers. So your takeaway from this is, look, these roles are mixed and varied, and who is doing them depends on the practice. Okay, number 1, reframe, numbers, let's get away from numbers. Number 2 was, let's think about roles instead of specific provider groups. Number 3 is, let's move from health workforce planning to planning for a workforce for health. What do I mean by that? So planning to support a workforce for health is going to really require boundary spanning roles. So our workforce planning efforts are going to have to include workers who typically practice in community and home-based settings, right? So when you think of the health workforce, who do you typically think of? Nurses, doctors, dentists, pharmacists. We're going to have to do a much better job thinking about a broader array of workers, social workers, patient navigators, community health workers, home health workers, community paramedics, dietitians, and other community service providers, because that, folks, is the workforce that's going to be needed to integrate clinical care with social services. And I don't know how many of you have been tracking the recent announcement that just came out about accountable health communities. Accountable health communities. Secretary Burwell describes them. We recognize that keeping people healthy is about more than happens inside a doctor's office. We're testing whether screening patients for health-related social needs and connecting them with local resources like housing and transportation to the doctor will ultimately improve health and reduce costs. So they've put up $157 million to test whether this sort of upstream approach, this upstream focus on transportation, utilities, etc., will improve health outcomes. Let's talk about this. Let's dig a little deeper. So the Accountable Health Community goals and aims, the foundation of this model is universal, comprehensive screening for health-related social needs, including housing needs, food insecurity, utility needs, interpersonal safety, and transportation difficulties in all Medicare and Medicaid beneficiaries who obtain care at participating sites. This is from a paper that just came out in the New England Journal of Medicine. This is what they're describing as an accountable health community. So it's interesting, I was totally struck. The news coverage of this described it as seamless social work. Seamless social work. And the New England Journal of Medicine article acknowledged a challenge to developing a workforce to deliver interventions to vulnerable populations. The New England Journal of Medicine article, was kind of laying out the challenges to really making this a practical, implementable, if that's a word, model. And one of the challenges really, who's the workforce that's going to be needed to assess, coordinate, and navigate patient needs? So if the goal of this initiative is to assess patients for these other risks, these utility risks or transportation risks or food insecurity risks, once they make the assessment and need to refer the person for services, one of the questions is the workforce even available to provide that service? And the second question is, do physicians, social workers, nurses, and other healthcare professionals even have the skills to take on these bridging roles? It's a great model. I think it's fantastic. I'm really excited about it. But I come back to you with the question is, who is this workforce and do they have the skills and competencies? Because one of the things we know from looking at the literature is everyone likes to talk about retooling the curriculum for the students who are in the pipeline, right? So what do we need to do to redesign curriculum? This is what we often focus on. When we need to be retooling, it says 3.9 million nurses, it should say 2.9 million nurses. I gave the nursing workforce an extra million people. Sorry about that. So we're focusing on the curriculum from students when I argue we should work on retooling the existing workforce. Okay, that's my fourth reframe. Because folks, it's the workforce that's in this system, in the healthcare system. It's the 2.9 million nurses who are already practicing who will transform healthcare. These are the folks who need these new roles. So we need to focus less on producing shiny new graduates and asking how many new nurses do we need, to starting to say, okay, so of the 2.9 million nurses that we have, what skills and competencies do they need? So we need to identify and codify these emerging health professional roles, and then redesign not only the pipeline, but continuing education, folks. We need to really be concentrating on CE. Where are nurses who are already in the workforce going to get these skills? So one of the things you also see, and you all know this, is that all these changes in payment policy that are finding hospitals for readmissions and moving towards bundled care payments and value-based payments, this is going to shift, and it already is, healthcare out of acute care into community-based settings. So when care shifts, right, the workforce shifts with it. So the shift is really occurring right now. Nurses are beginning to shift from inpatient to outpatient settings. But we generally, where do we educate and train nurses? Where do they do their rotations? They do them in acute care settings generally. We need to really build up the numbers of rotations and clinical practice opportunities for nurses in outpatient settings, because the current workforce is really not adequately prepared. Think about a nurse who did all of her education in acute care settings, has been practicing in acute care settings for 15, 20 years, suddenly is in a situation where her job is shifting outpatient. She's never worked in a primary care clinic. She's never worked in this environment. How does she make that transition? So this is one of the questions we have is, what does this nursing role, say, in a transformed primary care practice look like? And does that nurse have the ability to make that shift from the inpatient to the outpatient setting? So this is going to take an incredible shift in flexibility. Nurses themselves are going to have to really, and they have in the past shown this incredible flexibility. They're going to have to be able to kind of move with the system where they're needed. So one of the things Peter mentioned at the beginning in his nice introduction, that I'd worked for the National Health Service in England. And they have this wonderful quote: clinicians want well-defined career frameworks that provide flexibility to change roles and settings, develop new capabilities, and alter their professional focus in response to the changing healthcare environment, the needs of their patients, and their own aspirations. We don't have a system that supports that flexibility. We need more seamless career ladders to allow nurses to retrain to be deployed in different settings and to provide different services to different patient populations. We're not there yet. Okay, so that's sort of my laying out of what I see as the challenges. So great, Erin, fantastic. What do you propose we do about this? And it was funny, when I first started giving these presentations, I'd be out there and I'd stop there and I'd say, okay, I've reframed it for you. And people were like, well, what do you want? What can we do about it? Because this isn't just about nursing. Who else has responsibility? It's about education systems. It's about regulatory systems. And it's about reimbursement systems. They're going to have to retool themselves, these larger policy structures, to support these absolutely transformative changes in frontline healthcare delivery. So let's walk through these. Tom Ricketts and I had a paper in Health Affairs that sort of summarized what I see as one of the biggest issues. Is, frankly, folks, the education system is not well connected to practice. So there's revolutionary changes in the nature and form of healthcare delivery. You see this all the time in where you work. And that's beginning to reverberate backward into education as leaders of these new practice organizations demand that the educational mission be responsive to their needs for practitioners who can work in teams, be more flexible, and take on some of these new roles. But let me be honest, maybe it's different in your state, but in my state, the education system is pretty insulated from care delivery. There are some wonderful, spectacular examples of where that's not the case, but generally the education system is not connected in a real and tangible way to these frontline delivery changes. And I just had a conversation with one of our major philanthropic funders in our state, and I said to him, one of the things that you could do that would really help us is foster ways that the healthcare delivery system could meet with 2- and 4-year colleges to say, here are the kinds of courses that we need in informatics and patient coaching and care coordination. Can we have a module in these things? How are we going to offer this? Because I think we've got to much better foster these linkages between healthcare delivery and education systems to be able to create this workforce that we're talking about. And remember, we're not just talking about a workforce initially that's coming out of pipeline. We're talking about retooling through a continuing education program. So I would challenge you, do the continuing education opportunities exist either through your AHECs, through your community college system, through your 4-year institutions, through your professional associations? Do they exist to help retool the nursing workforce so that nurses are able to make some of these seamless changes? So I would argue that we need to redesign education systems so that nurses can flexibly gain these new skills and competencies. And if we're talking about the existing workforce retooling, that training is going to have to be convenient in terms of its timing, its location, and the financial incentives to doing that are going to have to be taken into consideration. If you're taking time off from work to go retool, we're going to have to think about how to make that a practical reality. But one of the biggest barriers we face is we don't have faculty to teach in these new roles and functions. Who understands? I mean, do we have the faculty to teach a course in population health management to nurses? Do we have the faculty to teach informatics? We're getting there. Do we have the faculty to teach, care coordination? We're getting there also. But we can't retool the workforce and create these educational opportunities if we haven't created a faculty to be able to do this. And the other thing is, I would really encourage nursing, as I have medicine and other health professions when I've given a similar talk. Think about your clinical rotations. Think about where to put them. Think about purposely exposing people to high-performing teams. One of the key elements of these new practice environments is this interprofessional focus, right? So try to get the nurses out into these environments, outpatient environments, where there's a strong interprofessional focus. So that's what education can do. But what about the practice side? For those employers who are on this webinar, we really, in the literature, saw that there was a lot of role confusion. That we had, as I mentioned, all these names of things, these different titles that meant different things in different practices. And one of the things that really has to happen is we've got to minimize that role confusion by clearly defining and training for these new functions. And job descriptions are going to have to be rewritten or created for some of these new roles. Once you create a new role in your practice or in your health system, your population health management, your informatics folks, your folks who are doing all the other functions that we talked about, health coaching, patient navigation, those workflows that you had, that you've become very attached to, are going to have to be redesigned around this new role. And one of the things that we see is a real lack of standardized training. So you'll see one practice that implements patient navigation one way, and the health system with whom they collaborate does it a different way. And we don't have to have everything the same, but we do need to have some elements of what is the curriculum for a patient navigator? What is the curriculum for a care coordinator? What is the curriculum for a health coach? What is the curriculum for a panel manager? We've got to understand what these core competencies are so that we can train to them. And we need funds to support training because that's a huge issue. One of the things we saw in the literature, and this was work done by Ladin and others, is that if you create new roles in a practice or a health system, and you say, here's Nurse Steve. Nurse Steve is now going to be our population health person, and you try to describe Steve's role. Existing staff sort of look at Steve and say, what is your role? How are you trained to do that? And one of the things that's pretty clear is other staff won't, they won't delegate, they won't collaborate if they don't really understand Steve's role, or they trust that he's got the training to do what he's charged with. So training is critical to this, folks. It is absolutely critical to the success of so many of these new models of care. And remember that in our jolly fee-for-service model, time spent training is not time spent on billable services. So for many places, this becomes an obstacle to sending your medical assistant or sending your nurse out for training. Okay, so that's the education and practice side. The regulatory system also needs to be restructured. This is from a paper that Catherine Dower, Jean Moore, and colleagues did. It's a real winner in health affairs. It's a great paper, and it basically says, the workforce innovations needed to implement ACA programs require an adaptive regulatory system capable of evolving with the healthcare system. So the health professions regulatory system in place today does not have the flexibility to support change, right? This is absolutely critical. Think about it in your own state. What's getting in the way of deploying someone the way you want to deploy them? Either a nurse or even, medical assistants bump up against this all the time. I can't be deployed that way because either there's regulation or there's some rule that I can't take on that role. So often we see that a lot of state legislators, who are the ones who negotiate these scope of practice wars, don't have the evidence to support regulatory changes, especially for new roles, right? All that they have is anecdotal evidence, and they make a decision based on anecdotal evidence. So what this paper really advocates for is better evaluation of some of these pilot workforce interventions to understand if these interventions improve health, lower cost, and enhance satisfaction. So remember that I started this talk with a look at sort of all of these new patient-centered medical homes, accountable care organizations, now these accountable health communities. Who's actually evaluating the workforce implications of them? And who's actually thinking, okay, well, actually the role of a nurse in this particular setting with this particular patient population had these particular outcomes. I think we can roll it out. I think we can change the regulatory system to support that. And one of the things that this paper calls for, which I think is very clever, is establishing a national clearinghouse to provide up-to-date and reliable information about scope of practice changes. So, if a state changes its regulations about nurse practitioners, that other states can actually look at that with the evidence that's coming out to say, no, we can do this. There is evidence to support this. Instead of it sort of becoming an anecdotal-driven fight at the legislature, which is often what it is in many states. So I also sort of want to end with this question, who's going to pay for all this retooling that we need to do? One of the things that's really fun, right? It's really fun that CMS is funding all these innovation projects. But many of these workforce innovations are supported by one-time funds. So if we don't move from a fee-for-service model fast enough towards these value-based payment models, or we don't have sustainable funding to support these new roles, can these interventions be sustained? So we have 1,000 flowers blooming But I would argue there aren't really adequate dollars to either sustain them or to conduct the research and evaluations necessary to develop the evidence base needed to support workforce design. We're not evaluating anywhere near what we should be evaluating. Often these evaluations that you see are about patient outcomes, which is really important, or cost, but we're not digging into sort of the process measures in between, which is really what was the workforce redesign, what worked, what didn't work, and how did that mediate or contribute to these better health outcomes. So I'd love to be able to see more funding for this, not just selfishly, but I think it would be great for the system. I want to point in the direction of 2 additional resources that you can read afterwards. The first is sort of a summary of everything I just talked to you about, which is a paper that we wrote on building a value-based workforce. That's on our website. This was work funded by HRSA. You can see our website there down at the bottom. It will give you an outline and more in-depth text on everything I covered today. The second thing was a Robert Wood Johnson funded brief that I had the honor of writing with Joanne Spetz and Mary Naylor. And it was called Nursing in a Transformed Healthcare System, New Roles, New Rules. This brief really summarizes the redesign that's needed to the nursing curriculum, the need for retraining. It really goes into some detail on revamping licensing examination and NCLEX, because this is a piece we didn't talk about. But it's not just the scope of practice regulations at the state legislature. It's also this question of NCLEX being able to keep pace with some of these new roles and be able to test nurses for some of these new roles. And then restructuring the state regulatory system. So if you want more information, I would suggest reading both our value-based brief or our Nursing in a Transformed Healthcare System, or if you have insomnia and want to go to sleep, back to sleep, you are welcome to read either one of these documents as well. No, really, I think they're good. That's the material that I actually have prepared, but I'm open for questions. And hopefully I can answer them, but if not, we'll try to answer them together. Thanks.
Great, thank you, Erin. That was a wonderful presentation. I'm going to, let's see, put us back on our slide that we had up. We can get our agenda slide back up, or we can leave Erin's contact information up if you'd like, Erin.
Sure.
And yeah, okay. As I mentioned before, if you have a question for a presenter, you're welcome to ask it under the questions portion of your toolbar. We have a few logged, but I usually start out the questions by giving our Center Director, Peter Bierhaus, a chance to ask one first. So Peter, if you have a question, I will let you take the first shot.
Okay, hey, thank you, Christy, and thank you, Erin, for your presentation. I always learn when I listen to you, and I've learned quite a bit today. But one thing I want to ask you, Erin, is if you had to sort of boil it all down to maybe 1 or 2 things that you would most recommend to achieve what you've described about a better configured, better prepared workforce, what would be on your short list of recommendations?
Oh, excellent. Peter, the #1 thing I think I would recommend is that we focus less on these shiny new nurses and more on retooling the existing workforce. I think nurses themselves, their professional associations and others have got to really concentrate on how they're going to help nurses gain some of these new skills needed to function in new models of care. I really worry. I met with a CEO of a major health system in North Carolina who told me that he was dismayed that he was having to lay off some nurses from an inpatient setting because their admissions had gone down, and they were trying to move these nurses to outpatient settings, but these nurses didn't want these jobs or couldn't move into these roles. And it sort of reminds me of sort of the manufacturing restructuring that happened in the United States when we sort of moved away from certain types of manufacturing towards different niche kind of manufacturing. And at the same time, we had to just totally retool our workforce. And it's the same thing happening here. So #1 takeaway would be, what do we all need to be doing in terms of supporting either financially or in terms of developing curriculum or whatever it takes to retool the existing workforce. The second thing I would say is we've got to put nursing rotations, we've got to move them out of the hospital into community-based ambulatory care settings. community health centers, FQHCs, and real put nurses in community-based settings, because frankly, that's where care is moving. And we need to give nurses the chance to be able to practice in these environments rather than educating them predominantly in these acute care settings. So those would be on my short list of things that I think are accomplishable and doable. And I put them in interprofessional settings too. Got 3 things, but 2.5.
Thanks, Erin.
Thank you.
Great. Okay, I have a housekeeping question that we'll take care of first, since there seems to be a few questions about it. Erin, I know we're recording today's session, but would you be okay with making your slides available to attendees?
Absolutely. Sure. So Christy has a copy of the PDF, so happy for that to be sent out. Sure.
Great. So for anyone interested.
Yep, sorry.
That's okay. Go ahead.
No, I was just going to say, and the brief is on our website, so, you know, and we welcome feedback on it too. If there's things that we've overlooked, would love to engage with you.
Great. So then the recording and the slides will both be available on our MSU Center's website, which that website is healthworkforcestudies.com. So if you're looking for that, and then the brief, as Erin mentioned, can be found on their website that's currently up on the screen, the healthworkforce.unc.edu. Okay, the next question I have, how can we assess the relationship between these outcomes, care coordination, value, etc., with changes in education system redesign? Is the BSN the quote-unquote secret sauce?
Oh, ask an easy question, will you? I mean, I think what you're asking is, you know, of these new roles, so let's not just concentrate on the BSN, let's think about the DNP and other nursing education roles. I think one of the things that we need to ask ourselves is, do these programs contain content in some of the areas that I've highlighted today? Is there adequate coverage of things like informatics, of geriatrics, of care coordination, of patient engagement? So has nursing education generally, not just the BSN, but also the ADN and the DNP and the MSN and other nursing degrees, do you think educators are adequately incorporating some of these new things into their curriculum? And so my second question would be, do you think that those educators are engaged with our frontline healthcare delivery people to really understand what is the nurse that you want to practice in your healthcare setting? What are those skills and competencies, and you know, what does he or she look like? So I'm not avoiding the question. I'm turning it back to say that I think it's about this alignment in whatever educational curriculum with you know, at whatever level needs to incorporate some of these new roles.
Okay, great. You mentioned lack of funding for the type of work you're suggesting. Do you have any suggestions or thoughts about potential funding opportunities?
If I did, I'd be chasing them. No, no. I mean, I think part of what we all have to do, we as workforce researchers, we as educators, we as nursing professionals, we as health employers, we need to be getting up and saying to folks, and when I say folks, I mean national funders, you know, that these workforce questions need to be critically evaluated, and that it's not just about changing the care delivery model or changing the payment model, that there's a whole host of other things that need to happen to the workforce in between. So if you're talking to HRSA, or you're talking to ARC, or you're talking to PCORI if you're a researcher, right? Those are things that we need to be pitching, is that we've got to be saying, you know, we're spending millions of dollars on these new models of care. Are we actually evaluating these outcomes? Because I don't know what it's like in your state, but in my state, people like to do. They don't really like to evaluate. So we have to kind of convince people of the value of these evaluations. If you're at a state level, you know, I think that foundations are increasingly open to this. So your private philanthropic, you know, organizations in your state, being able to make a compelling case around the need for retooling and this workforce research and other research that needs to support it, I think is critical. So I do think there are funding opportunities, but part of it is that we need to be engaging and educating people about the fact that this isn't being done and how important and valuable it is to kind of shaping, the future. I mean, one thing that gets me is we spend millions upon millions of dollars on education programs, on all these sort of health workforce interventions, but I'm not sure, A, we know where we need to be putting our efforts because we haven't done the homework on the front end, and B, whether these efforts are making any difference so we don't do the evaluation on the tail end. And so those who know me tend to know that I'm a little bit blunt, but I think it can't hurt to be blunt. And I think chasing money and kind of getting this message out there, it would be great if you all could help do that.
Excellent points. Okay, switching back, what are some examples of pilot workforce interventions? G&E demonstrations, as an example, I think they're asking about.
I actually hadn't thought about graduate nurse education, G&E. I mean, it certainly is a very important intervention that's going on right now and has had some evaluation. So I think that's important. I wasn't actually talking about that. I was talking about interventions that use nurses in different ways. So one of the things that we hear a lot about is that a lot of nurses are sort of moving from direct patient care into these broader roles within a larger health system or in a primary care practice that's transforming. So they're actually, for example, maybe the nurse is the one that's using the EHR data or the patient registry to figure out which of the patients, the diabetic patients, are not coming in for foot checks or their regular checkups, or which of the hypertensive patients haven't been refilling their meds, or which of the people at high risk for breast cancer are not coming in for mammograms. So the nurse has actually moved into a role that is actually more population health management. So that's a nursing role, an intervention role that is different than that sort of direct patient role that nurses have more typically been in. But there's also all sorts of nursing roles around patient engagement, nurses who are actively involved in working with patients and their families around, educating them about their disease, about medication adherence, about healthy living. And so that's another role. So that's when I'm saying these interventions are sort of the use of nurses and MAs and social workers in new roles, right? And so they're being deployed in different ways now than they were in the past, and that's how I'm using the term, perhaps too loosely if anybody's a real person, researcher. Maybe I'm using the term intervention too loosely, but that's how I'm thinking of it. So these are some of the things, this deployment of nurses in new roles. I would like to be able to evaluate that a little more clearly and understand the effect that that's having on costs and outcomes, but also on the healthcare team more generally too.
Great, thanks for clarifying. Considering the 2.9 million RNs and a 5th-generation workforce in healthcare, how would you propose we best address the retooling, with the belief that a certain portion of these RNs may look to retire over the next 3 to 7 years?
Okay, so if you say a portion of these nurses are just coming in and a portion is retiring, what percent that's going to leave you with in the middle? I would argue it's probably still a good 75% of the workforce. So I think that's a very real question, is that, as practices change and as people lose their jobs in acute care, they may not be willing to shift over to an outpatient setting. But I still think that we've got to focus on that middle group. So maybe that's not 2.9 million, maybe that's, I don't know, 2 million nurses. I mean, fundamentally, the point that I make is nurses are the largest licensed healthcare profession. They're the group that will be actively transforming care. So we need to be concentrating on any ways, either through continuing education, through more flexible regulatory systems, through educators engaging with employers to redesign roles. We need to be kind of actively thinking about it. It's really interesting. I have a slide that I sometimes show, and you have to envision it in your head, of a person, a stick figure, with one foot on the dock and one foot in a boat. And the boat's sort of getting farther and farther away, so that this person is sort of got one foot still on the dock. It's a very uncomfortable position. I would argue that's sort of where we are right now. Okay? And the thing is that health systems when you talk to them, know that this is just around the corner, that these new payment models, full implementation of a lot of these roles is just around the corner. But they're not clear how they're going to do this either. So I think we don't know for sure what that future healthcare system is going to look like, but we do have to start preparing now. And I think we do need more flexible education and regulatory systems to address this middle group. And I would argue that it would really help to know why those nurses are retiring, right? I'm totally intrigued by Peter and David and Doug's work, that really looks at these changing retirement patterns. And we've looked at them quantitatively, but it'd be really interesting to sort of look at generational differences and actually figure out if people are retiring actively because they don't want to face this. And I don't know, Peter, if you've done that, but that would be an interesting research question.
Yeah, related to that, this one kind of builds off of that, so I'm going to pull this one next. It seems like the disconnect between educational systems and healthcare delivery systems appears to be a concern, not just with nurses, but with doctors, NPs, and PAs as well. Do you think a postgraduate mentoring program provided through the education system and the healthcare-placed graduate would be of benefit both to the graduate and the educational system? That way there's a more practical hands-on connection.
So having somebody who's a postgraduate who's in the system actually mentoring someone who's in the pipeline, I guess, is what, I mean, that would be an interesting way of then feeding information back to the back to the education system. I think it's a novel idea of connecting those two. And that's exactly the sort of idea we need to be looking for, is any way to connect the active practicing nurse with the nurse who's coming through the pipeline. So I think that's a great idea.
I have another question about curriculum. Is there a curriculum that you're aware of currently that provides online continuing education opportunities for existing RN staff related to the new care models and new role opportunities?
The short answer is no. And so let's think back to the really great suggestion that Catherine Dow or Jean Moore and colleagues made about an inventory of regulatory changes. Why wouldn't we create an inventory of sort of online education modular courses that could be taken by nurses to be able to retool? I think that's a great idea and fundable if somebody's interested in doing it. What we've seen much more are individual practices or individual health systems developing their own curriculum. I mean, one of the things that strikes me, and Peter's a senior workforce researcher in nursing, and I'm nowhere near that level of knowledge, but as I'm kind of looking at this and talking to folks about nursing and the need for this retooling, I'm struck by the fact that for a long time hospitals took on a lot of the cost of retooling the workforce. So there's a lot of hospitals out there where they have, a fellowship, and I have air quotes around that, where they take new grads and they integrate them into practice through this fellowship program, right? So if you're in ICU, you're doing one fellowship, and if you're in L&D, you're doing a different one. And so one of the questions I have is hospital budgets start to get constrained, and they start to see, and they already are, cost issues. Are hospitals going to be willing to take on that sort of transition to practice education that's been going on? And if hospitals aren't, who's going to do it? Or if the nurse transitions directly from a nurse, graduates from a program and goes directly into outpatient care, and it's a small practice, how's that going to work? So I think that this whole issue of transitions to care, which is really where the rubber meets the road in terms of the graduate, getting employment and perhaps not meeting the expectations of the employer. This is another incredibly rich area for research, an incredibly rich area for collaboration between education systems and frontline delivery systems.
Great, that's a good point too, Erin. Peter, I'm going to switch back to you and see if you have one more question for us, maybe to round out today's webinar.
I think it would be maybe just to build on one point, Christy, that Erin was making, and her plea to use and retool the existing workforce. Erin, I can't agree with you more. I think it's going to be challenging for many of the reasons that you've expressed, but I'm also optimistic because I think we're talking about a workforce that has anywhere from 10 to 30 years of experience, of knowledge, that has a fundamental innate understanding of healthcare delivery and of the organization that will be changing. Also, they're highly satisfied with their career. Those that are still in this workforce by this time, at least our studies showed a consistent pattern of anywhere of 80 to 90% of these nurses saying they were satisfied with their careers. So I think they may be in a position to implement some of these new roles, maybe not on a full-time basis, but certainly on a part-time basis, or be willing to stay involved. So I think there's a tremendous reservoir there. I'm very glad that you are getting us to think about really more about what this existing workforce should be and can be retooled to do, and not so much always to focus on the numbers. Do we have enough nurses? What's the demand? What's the supply? So, Erin, I just want to say thank you for being with us, closing out our webinar series. And I think we've had a very strong attendance on our webinar today, so I think that attests to how people view your thoughts and ideas and opinions. So thank you again. Christy, let me turn it over to you.
Great, thank you. And I think that's a great note to end on. We had some other questions, but I don't think in the interest of time we're going to be able to get to them. So I appreciate everyone's participation, and this has been a great discussion on top of an excellent presentation. So I want to go ahead and say thank you to our presenter, Erin Fraher, for agreeing to come on and talk with us today, and I thank everyone for taking time out of their busy schedules. Of one note, we will be continuing, despite the fact this is the last event in our webinar series around value, we will be starting a new series next month and going through May, where we're looking at other issues, new data, new research around the nursing workforce. So stay tuned for updates and scheduling related to that webinar series. And we thank you very much. Have a great afternoon, everyone.